So welcome to our one more meeting or GNT of Ghana or Dr. Teixeira or Dr. Ghanem, Dr. Teixeira, how you want to call it, or Gin Tonic, as we talked about, is our preferred drink. Um, we have a special guest today, an orthopedic surgeon from California, Dr. Basmajian. I'm not going to try to say his first name. Dr. Ghana is going to say his first name, but I'm going to call him Muhammad. We're going to call him Andre, and Ghana is going to introduce him his first name. It's too many R's for me to say it, but it's awesome to have you here. It's always interesting to see the relationship between obesity and orthopedic issues, right? And I'll let you kind of introduce yourself, see your background, what you do, what's your specialty, like full scale, and we'll go from there.
Andre, Mohammed, thanks for having me on. I like G&T better, actually. So I appreciate you guys having me on. So the first name's Hrayr. Yeah, it's Basmajian. So I'm from California. I do joint replacements and orthopedic trauma. That's my specialty. We're part of a multi-specialty orthopedic group who does, the gamut of sports, hand, upper extremity trauma, and joint replacements. And yeah, so my specialty is the joints. And, I kind of I grew up in Detroit and did my training out here at USC in Los Angeles, and then ended up staying out here and joined a large academic group and was the head of orthopedic trauma at a large level 1 academic center. And then, decided to, kind of build our own program. And so we joined a hospital here in Los Angeles and built a whole trauma program and a total joint program. And we're very happy out here. We love it, and we get to deliver the care the way we want to do it. But yeah, obesity is a large part of orthopedic trauma world. It's a huge part of total joints. We're constantly battling, what's the right thing to do for the patients, because really we want to take care of these patients. We want to take care of all patients, but obesity brings a totally different factor into it. And I think my interest in trauma and total joints, trauma seems to be, we've got a lot of patients out here who love motorcycles. We're right in the middle of all the highways. And it seems to be every single person out here who's on a Harley is, a larger American who loves life, who loves to ride their Harley. And, unfortunately, the cars like to not see them. And that's where they end up.
Well, first of all, thank you for coming, Dr. Basmajian. And I know we scheduled this a little bit later on. It's in the middle of the week, and I know you were operating today. So tell us, how does your typical day look, and what cases did you do today?
Thanks. So my typical day doing trauma and joints is kind of an interesting setup. And so what we'll do is, my typical day like today is we'll put in one total joint today, just given the whole COVID thing again, of course. But normally we'll have 1 or 2 total joints in the morning, and we'll do those patients. A lot of those patients nowadays we're doing the joint in the morning. I'm doing hip replacements. I do anterior hip replacements. So we're doing the anterior hip replacement. They're getting up, walking. They're going home. I would say about 60% of our patients are getting up, walking around, and surprisingly are choosing to go home after that later on that afternoon. The other half of our practice is all the trauma that came in overnight. So, for example, during today was another 6 trauma cases. You guys were nice enough to make this a little bit later in the day. Couple of the patients turned out not to be so optimized. They weren't quite ready for surgery today. So everything kind of worked out to make it here on time. And so what I did is my total joint, and then did 4 more trauma surgeries on top of that. And then, we manage those patients. We do their surgeries. We talk to their families. A couple of the cases today were stage surgeries. And so today we did a stage, what we call a pilon, so a bad ankle fracture. We did an elderly patient who has a hip replacement who fell and broke her femur underneath that. And actually the one I just did right now was a fairly obese lady who just took a wrong step from one step out of her house and ended up shattering her entire knee. And so that was kind of unfortunate. We actually had to move some other cases around to get that one done just because it was so urgent. But it's kind of interesting that that's what we're going to be talking about today.
That's kind of cool.
Really, what percentage of your patients or practice that you actually see that suffer from obesity, and how do you think that impacts your practice?
Again, I think you got to divide it into the 2 sections, right? In our total joints, I would say about a third of the patients are obese. Mm-hmm. I would say about a quarter of them, when they first present to us, are excessively obese to the point that, we're not comfortable offering a joint replacement yet. I don't believe in this idea that somebody who's suffering in pain is not going to get any sort of treatment. And I think that's where we start coming up with a plan and coming up with, what is our goal and how do we get to that goal? And that goal really, involves us, but it really involves their primary care physician. A lot of times it involves surgeons like yourselves. And, but I think out here, the issue we run into is there's not always access to surgeons like you to get, for every patient to get the care that they need. I think in the trauma side, I would say good 30 to 45% of the patients who come in through the ER with bad traumas are morbidly obese. Between that obese and morbidly obese, we do get some of that severely kind of just excessively obese where we start considering, can we even operate on these patients? And those we're talking about, bad pelvic injuries or bad femurs in patients with BMIs in the 60s. And, I think that makes it very complicated for us. The risks go up tremendously, and we can talk about that if you guys want.
Good question. So, what is a cutoff number for you? Like, for example, for us here, a lot of our orthopedists don't feel comfortable in doing joint replacements on BMI greater than 35. Okay, for specific risks of infection, hardware infection, and so forth. But what we found is we have a very heavy trauma institution, orthopedic trauma institution, Orlando Health. And we have pretty aggressive and amazing orthopedic surgeons like yourself here too. They are comfortable in doing some cases, selected cases, higher BMI, as long as they just had maybe a month or 2 months prior a bariatric operation. Why? Because they feel that they're going to be able to lose more weight, right, by being able to get more active, and they would achieve that lower weight and the lower BMI. They were thinking about it. I don't know what you think about that idea, because we get both ways. We get patients that they want them to lose 200 pounds prior to surgery, and I'd say sometimes they can't lose 200 pounds, right, without being active. So I don't know how you guys do it.
Yeah, it's a great point, and I think what I found interesting when I first started doing this is you'd work with surgeons who just look at patients and say, "Well, you're too big, we can't do this," and you're like, "Well, there's got to be an option out there because the patient's suffering in pain, and so you got to do something about it." Orthopedics is really just I consider a different version of joint replacement is a different version of pain management, right? We don't want to put our patients on chronic pain medicine for the rest of their life. So we have a much better solution. It's a 1 hour surgery, 1.5 hour surgery, and your pain is gone. And so I agree with you. I think trauma allowed us to see, for those of us who do a lot of trauma, I think it allows us to notice that a lot of these patients, when they come in, if they break their femur, they break their hip, and they get a hip replacement, we're doing this in BMIs of 40, 45 sometimes. Our answer is, well, we don't have a choice. It's not elective at this point. But some of these other patients who are coming in for very severely progressed arthritis, who are in a lot of pain, it's really not elective for them either, if you ask them. So, yeah, I think for us, we've made our cutoff at 40. And there's a lot of good evidence in this. And really 35 is something, for example, like the VAs have done, the veterans have done, and some of these other hospitals have done. But the evidence is really good at around 40. We've made our cutoff at 40, but what we've done is exactly what you said. What we've said is if the patients have lost weight, if a patient can lose 30 pounds, and get to a BMI of 41 or 42 from 43 or 44, there's good evidence that actually is a sign of a patient being able to do well after a total joint.
Right.
So if they've gotten their surgery and they're starting to lose the weight, we don't make them wait till they get all the way down. It shows us a patient who's committed, who's motivated, who's also has done the right steps, I think. And the evidence is agreeing with us that if patients are starting to lose it, they actually do much better than patients who are just at 40 and don't want to go down even a little bit. The patients who are at 43 and drop to 41 do much better than the patients who are just chronically at 40 and refuse to do anything else.
Which kind of resonates with us too, because, most of our patients have to diet prior to surgery. And we also notice that those who lose weight prior to the surgery are the ones who are more committed, who are in the right mindset, which is something that Dr. Teixeira and I kind of touched on the first episode, really, that those are the ones who do better on the long term, rather than the ones that they say, I'm going to do the surgery so I can eat whatever I want now for the last month and then gain even some weight beforehand. And they tend to do less well on the long term.
Yeah, I agree. It's very interesting how the person's that the patient's, attitude and personality
Right.
and motivation really makes a difference. Somehow it converts somehow into their positive outcomes.
Right.
100%.
You've kind of touched before about the complications that morbidly obese patients can have when undergoing joint replacement or joint surgery. Can you touch a bit more about those and educate the patients more about those as well?
Well, what we're doing nowadays, obviously in the U.S., is that patients are demanding more, they want more, and I think they deserve it. They deserve to be higher functioning and maintain that function. So we're really doing these joint replacements. We're pushing the boundaries, we're pushing the limits of it. And what we're noticing is that patients who are obese are having higher risk. Number one, initially you have higher risks of infection, just wound complications. That doesn't always translate to a deep infection, which is really what we're trying to prevent, but it does complicate the scenario quite a bit more. So for example, even something simple as, I do an anterior hip approach, like I said, we glue our incisions. It's usually a little 2.5-3 inch incision, and we glue them shut. People like them. They're cosmetically appealing. But when we start getting patients, are more obese patients or overweight patients, we're doing different things. Now you're getting staples, you're getting sutures,
Yeah.
you're getting a vacuum incision, you're getting a vacuum dressing on top, all these things to keep that sort of, that belly, that pannus from wearing down the wound and opening it up. But they do get quite a bit more of those issues. The other big thing that I think that people don't talk to their patients about is this, we call it aseptic loosening. It's probably the biggest thing that happens with the obese patients is that these implants, we want these implants to be lifelong implants, right? You get this implant, you don't want to go through this again, even if it was it was a fine experience, you enjoyed it, you told your friends, hey, I would do it again.
Mm-hmm.
Doesn't mean you really want to do it again.
Right.
It would just be silly.
Yeah.
So I think what people are getting is what's called aseptic loosening. So meaning that it's not an infection, but the implants are slowly loosening. And so that's one of the biggest things that is happening in obese patients. And we're not noticing it till later. And so the evidence is slowly trickling in that, hey, these patients are not doing as well long term. So instead of this implant, when I'm telling a patient it's going to last you 25, 30 years, it's lasting maybe 15 years or 12 years. And, you don't want to do this again in 10, 12 years. And the last thing I think that patients is what I see a lot of, because I do a fair number of revision work, so redo work, is malposition. And so what they're doing is the surgeon can't see as well because everyone's stuck to this idea of the incision has to be small. It's got to be perfect. And so when you start getting larger patients, it's harder to see what you're doing. The equipment doesn't fit in. And so what you're doing is you're leaving implants in less than ideal positions and, or leaving the limb maybe shorter than you would or longer because you just couldn't get the right feel.
Mm-hmm.
And what's happening is, so that leads to higher dislocations. So the joint, the hips, for example, popping out of place, it's leading to higher wear rates because now the implant, the companies love to tell you the implant lasts this long, it can undergo all this. But really that's if it's put into the right place, it's put into the right position, and the patient's taking care of it the right way.
Correct. It's the same thing with us, right? In terms of bariatric surgery, they want to hear that we can do this operation and it's going to last forever, right? Same thing. If you don't take care of the operation, don't overfeed, don't drink a lot of carbonated drinks. Yeah, the pouch size, the sleeve size, all is going to stay pretty much similar to the same size, right? So if you have a weight regain, it's not because you stretch the pouch, it's because you have some dietary, right? So you still have to do what we call the TLC, right? So it's interesting. That's a connection between both procedures, right? Both fields that you still have to take care of it. Like my dad. My dad has a total knee done 5 years ago, and he really takes care of it. He babes that thing because they allowed him to walk again, right? I mean, he's 74 now, and he was having a hard time walking, and allows him to go back and still practice medicine, right? So without any discomfort, walking, doing rounds, seeing his patients. Before it was a little tricky, but so he said, I don't want to ever have to have this again, but I'm gonna take care of it so I don't have, right. I think there's very few field in surgery that patients wanted to come back and redo it. I'm not gonna say what they are, but like plastics maybe. Some patients want to have other ones, you know. But my question for you is that how can we educate our patients, right? Once they start losing their weight, right? And what I always told them is if you take a video of yourself walking the day before your surgery, and you take another video 6 months later, you're gonna see the way you're walking is different, right? Because your realignment, your hips, your joints. So what can we tell them that will make their discomfort better when their realignment starts happening? Because they started having a little bit of joint discomfort or tailbone discomfort, some back discomfort. But I think also is, which maybe you can expand on that, is core muscle, right? They have to realign that too. So I'll let you kind of maybe help us out with that.
And that is actually, I'm going to just resonate that that's one of the most common complaints that I see as well. I'm pretty sure Dr. T
Yeah.
has seen that quite a bit. They come back after they lose weight, 3 months out. The first complaint is everything feels great, but I have horrible back pain now.
Yeah, I think the core is probably the most ignored but most important part of our body,
Hmm.
right?
Hmm.
And so, especially in America, I mean, it's really not something, we all want a nice core, maybe cosmetically, but I think people underestimate the purpose of it. I get patients all the time. They say, "Well, I've got this bad hip. Why are you sending me to therapy?" And and then so many of them, I would say about 80% of them, come back a few weeks later, and I'm like, "How do you feel?" And they're like, "Oh, I feel great. It really did help. I mean, my hip still hurts. I still want the surgery, but I feel so much better." And so it's the same people who said, "Why would I go and do
Correct.
this, physical therapy?" And all the therapists are focusing on is core and leg strength. So what we do is, there's a lot of evidence that for hip replacements, for example, you don't even need therapy afterwards. But I like to send my patients because it's exactly what you said, Andre. I mean, I want patients to go and work on their core because now you've got this new hip. It's like losing a bunch of weight, right? Like once you lose all the weight, yes, you're happy and you probably feel better, but now is the time to really let's work on it some more. Let's get the rest of your body strong again because now you're able to move around better. I think the other part we didn't really touch on is I've had multiple patients that I've sent to surgeons like you and to get the weight loss surgery and lose the weight. And I can't tell you it's probably bad for business because a lot of patients come back and they say, "Well, I feel great. Thank you for sending me. I lost the weight, but my hip I don't feel too bad anymore." And
Right.
so I'm just not, which I find really, I mean, I love that joking about it, but I really do like
Mhm.
it. And I think it makes us feel like we're doing something right for the patients. There's a lot of evidence that, let's say you're doing stairs. I mean, every pound is about 7 pounds on your knees every time you do stairs. So imagine that. If people can lose 10 pounds, that's like 70 pounds off of your knees every single step that you take. And
Wow.
so what you guys are dealing with is people, helping people lose, 100 pounds, maybe more than that.
Correct.
And so that's a significant difference. I mean, I just recently lost, 30 pounds myself, and I feel way better, and it's much easier to move around. I mean, you're not getting as fatigued, and so I can just only imagine for someone who's got the arthritis, has the joint pain, who can then be empowered by losing the weight and get back to a more active life, and maybe even do it without having to do the joint replacement.
And that is funny that you touched on this because, I always say I relate to that. You go on vacation or the holidays, you gain 2 or 3 pounds and you go for a run and you feel a tremendous difference how much knee pain you have afterwards. So you can only imagine how much our patients really suffer through and why it becomes a vicious cycle that they can't really exercise because of that, because they're having knee pains or back pains as a result of that. And then as a result, they end up getting even more pain and so on and so forth.
It's funny. He runs like zero point 0.5 miles a day. I mean, who runs that? I don't even call it a run. That's like speed
He
walking.
is he is just jealous. I run 5 miles, and he probably has never ran in his life, even if his life depended on it.
I just came back from Christmas and New Year's holiday from
Right.
Detroit and put on a good like 8 pounds, and I'm looking at that Peloton. I'm like, how am I going to get back on this?
Listen, so I got a Peloton because my wife wanted. We want a Peloton, right? So I started using it. I used it for like 3 days, and I haven't used it again. So I'm going back again. I started using again. So back on the saddle. Right? It's a great way to lose anything that you do, right? That gets you out of your comfort zone is a phenomenal way, right? it's one way for you to lose weight that's going to benefit everything, right? In terms, especially joint and muscle, tendons, and so forth. Because we focus so much on bone only, but we forget, right, that you also have a lot of muscle issues, tendon issues with obesity patients, right? With obese, because it's all an inflammatory disease, right? That's why you see all those rheumatoid arthritis. Um, Talking about that is interesting. I'd like to see how there are some patients that we see there have not been taking their vitamins the way they should to take it for a long, long time, for like many years, right? And some of those patients can develop osteoarthritis, osteoporosis, and so forth. Um, the question is, if they come to you, a bariatric patient with a joint issue, low calcium, bone density scans low, what is your how you deal with those patients?
Yeah, it's a problem, and it's interesting that more patients are being educated about it because they do ask about
Mm-hmm.
the same things. Normally, what we're starting with is what's one of the biggest things for me, and you guys probably deal with this all the time, is trying to convince someone who's overweight that they're actually likely malnourished.
Correct.
So we have this conversation, and they say, "Well, what do you mean? I eat plenty," and you're like, "I get it, but there's a lot of good evidence that you're actually malnourished. You're not getting the right type of vitamins, the right type of calories that you really need." And so I'm sure you guys deal with that. So I like to involve, my best patients are the ones who have a very involved primary care physician, someone who's get a nutritionist involved with. I always start with vitamin D, number one. Initially, when we started doing this, 10 years ago, I would get calls from pharmacists saying, "Why are you writing this patient to have this much vitamin D?" So I usually, the older patients with osteoporosis, I put them on 5,000 of vitamin D3 a day. And now it's becoming so much more common that I don't really get those calls anymore.
Correct.
We get them on that. We get them on a healthy diet. And then we get them on some sort of an exercise plan of any sort of weight bearing. I think what's interesting is it was funny because when I first got my parents on it years ago, my dad would laugh, and he's not with us any longer, but he would laugh because he said, "I'm going to the gym and people are looking at me." He's like, "You have me lifting these few pound weights," and trying to explain to them that any sort of weight bearing exercise is actually good for your bones, good for your muscles. You don't want to, if you're overweight, trying to get out there and walk is a very difficult thing to do. And it's another reason why I think things like the bikes and these other things have gotten so popular, because it's much easier to do that, combine that with a little bit of light weight training, and then we get them on a healthier diet. We really try to get them to, surgeons like you, get them to a nutritionist, and then they start understanding that, hey, I am malnourished and I need to do this. The vitamin D is interesting because, we live in California, and, you guys are in a sunny place too. And people look at it and they say, "Well, I get plenty of sun." And I think that's an old belief. It's an old idea. It's completely disproven now. People who live in sunny areas don't get enough sun to get enough vitamin D these days. Everyone's sunblock. They're doing other things. They're covering their skin so they don't get, skin cancer, which is also important, right?
Yeah.
And so really, I don't know any person, above the ages of about 50 or any postmenopausal patients who don't need to, supplement with vitamin D. So I always start everybody on vitamin D3, healthy diet. A lot of my patients, I'll put them on sort of some of these, vitamin or boost drinks so they can, whatever company that you like. I usually allow them to talk to their nutritionist and help them get on that. But I add those kind of drinks in there to get the better calories for them. I don't know what you guys feel about those kind of drinks, and are they too high calorie, or what are you doing?
Some of them are actually high calorie. So we always do recommend that eventually they end up reading the label. And honestly, once you do that, that will tell you a lot. I myself, for one, I did not get into the habit of really just taking whatever I drink or whatever I eat to just basically flipping that side and taking a look at the label and see what's going on there. And oftentimes you will see a lot of hidden stuff in there that, they'll market themselves. For example, we deal with, probably less so with these vitamin drinks, but we deal with a lot of protein, right? Shakes and et cetera. And those protein bars, all you have written in big bold letters, 30 grams of protein or, 20 grams of protein. And you flip it on and you see also there's probably like 80 grams of sugar in there. They just don't mention that, right? So unless you read the label. Right, exactly. It does. And so really, once we teach them to actually read into the label, they kind of eventually educate themselves, and they learn with time what they really should be doing, what they should not be doing.
Last couple of years, started seeing more. It's the protein drinks, right? But usually they are chalky, right? So we started seeing the the clear liquid protein drinks, which is basically it looks just like a sport drink, right? And it tastes like one. So we tell the patients, like, listen, you don't have to do the chalky one. You can do this ones now. If it goes down better, it's more soothing. It's just like a sport drink. At least you get, instead of drinking a soft drink, right? While at work, you can drink this. At least you get some 30 gram of protein, or how many protein grams in there. But it's more than you're probably getting before when you're just drinking a soft drink, right? While at work and so forth. So I think the secret between individual practices in the end is working together, right? Team approach for those patients, right? I think the orthopedist and the bariatric surgeon and the primary care physician, the nutritionist, the psychologist, all working together, we are able to move this patient to a better place, even if does not need bariatric surgery or does not need orthopedic surgery in the end. At least everybody had the same goal, which is get this patient healthy, right? Because we do get patients, they are sent to us for weight loss surgery, right, before an orthopedic procedure. But we tell them, like, hey, let's try this first, right? And then if you lose the weight what they want, they will do your bariatric procedure. And some of those patients, they lose their weight with medications, lifestyle change, coaching, and they don't have to have the bariatric surgery, right? You put them in the right track. So I think that's the key, right? The key is working together as a team, right? And I don't think we should, like you said something, which is also a kind of an old thought, right? Old school, which was afraid to lose the patient, right? That is so classic, right? From my dad's time, right? That was how it used to be. My uncle, which is a little bit Joanne, another one that I have, which my other uncle is a neurosurgeon. They're all old school and they all thought about this kind of stuff, right? So, and now it's not that. It's more patient centered.
We always tell them we don't want just patients, we want successful patients. And if really, with obesity nowadays, if you close your eyes and just grab somebody in the street, chances are they do qualify for surgery, but that doesn't mean we should take them to surgery, because if they haven't really made that mindset change in their minds and they decided, hey, we want to do the surgery, we want to do the lifestyle change, they're not necessarily going to be successful. Yeah, they'll have the surgery. They might lose weight the first 6 months or a year or so, but then eventually they'll go back to their habits and then end up gaining the weight back. And it's exactly the same thing of what you and Andre were kind of saying a second ago.
I have a question for you. So we are very heavy robotic practice. Pretty much 100% of our cases are done with a robotic device. And there's only one in the country for soft tissue right now, which is Intuitive. That's what we use, right? I can tell you that in our institution, for whatever reason, we are pretty blessed because they really truly believe in robotics for everything. So we have, you can imagine, every robot in the market we have, especially for bronchoscopy. We have all four on the market. We have it for back. We have the Mako. I guess there's another one for orthopedics. I don't know them very well because it's outside of my realm. Do you mind? I mean, if you work with them, I mean, do you use robotics and what do you think about it? What's the future going for orthopedics on that level?
General surgeons and you guys are kind of paving the way of that. Obviously, that the robots that you mentioned are kind of the leaders in that, and it's very big in orthopedics. It's really moving in. It's a lot of times it's combined with sort of active image guidance, and so you're getting the image at that point, and then using the robot to do that. A lot of times we're planning in what we're doing is taking images before, like MRIs or CT scans, plugging it into the patient, plugging it into the robot, and then in the Mako, for example, like some of these are doing most of like a knee replacement for you. I think it does make it more accurate. I think it makes it safer. There's some learning curve on it. I think to ignore the robot is to say that you're just, you're putting a shelf life on your practice.
Correct.
I think patients are demanding it. I think some patients are not understanding where we are in orthopedics with it yet. I don't think it's not leaps and bounds like it is in some of the fields yet. It doesn't really make the surgery less invasive at this point. It makes it more accurate sometimes. And so I think if you're doing, let's say, a knee replacement or a hip replacement with somebody who's not doing as many, the robot really allows them to start comparing themselves with people who do much more. Mm-hmm. I think for people who are doing, a few hundred of these, a year, the robot doesn't really make them much better yet. But I think it's starting to get to the point where every generation of robot in orthopedics is going better. Mm-hmm. We're not at the point. I think 5 years we'll be at the point where we're sitting behind a cubicle, just like, some of the other robots, and the robot is doing everything. And you can imagine the incision's smaller, imagine it can do all of the implants, and, and actually probably better for obese patients because the visualization is much easier because it doesn't need to see like we do from our head to our hands. It can see around corners and do all sorts of different things. So I'm very excited about it. I'm interested to see what our future looks like. I think in the end, it's better for patients once we can make sure the cost benefit is in the right place.
The cost benefit has to be in the right place. Outcomes has to be at least the same. It cannot be worse, right? Outcomes always be the same or better, right? And I don't think physicians or practitioners should not be scared of the robots, right? I mean, because it's truly a device that helps you achieve some difficult cases, make it very easy, right? But nothing's going to replace, I think that's what people are worried, nothing's going to replace the clinical judgment, right? Or we call the Gestalt feeling, right? That comes with practice, and that you cannot teach. Make sense? So I think we have to still understand and know what is a clinical judgment, when is the right time to operate on the patient, right? And when not to operate, that's the hardest part, when not to, right? And that's where experience comes into place, right? Yes. When they're able to make those decisions, they're not afraid of it. So there's no robot that will ever surpass that. So we're still going to have our jobs.
Yes, I think in the future, the far future, I think there will be, because I think eventually all of what we mentioned will eventually algorithms that they can basically kind of create, and eventually they can create some sort of algorithm to when they can do that. But I think there's going to be a very distant future kind of thing.
But we'll be the ones to teach it that.
So
Exactly.
Let me ask you something that, we kind of talk with patients a lot with joint issues like we talked before, and we kind of always want to break that cycle, and we touched about it beforehand about the sedentary lifestyle. We want them to be active. What are physical activities that are joint friendly that you would recommend to our patients with somebody who has joint disease or joint pain, and yet you want them to be active? I know biking is usually one of them. I know swimming is usually one of them. What else? And what would you recommend?
I mean, you hit it right on it. I think all these low impact exercises, right? So I never tell anybody to go out, walking if they got joint pain. I definitely don't tell them to run. I don't tell people with healthy joints to go out and run. So Mohammed, maybe that half mile's not worth it, man. I tell people always, biking, and that's kind of how I got into it. Is I kept telling people to go bike, and I was like, oh, you know what, maybe I should do it. And so I took my own advice. So biking, swimming is always great. We do like things like yoga and things like Pilates, and these things these exercises that really focus on core. The amount of injuries that we get from people who say, I'm going to get up and I'm going to work out, and they start like CrossFit or they start one of these other things, and it's like you can work your way to some of these higher exercises if that's really what you want to do. Mm-hmm. But, if you want to just not live a sedentary lifestyle because you want to be slightly healthier, there's bikes, there's elliptical machines, there's swimming, there's, going and doing, almost anything in a pool. There's you can go and play like, couples tennis, or two-person tennis. You can even go out and golf and walk the golf course. Don't get that cart. All these things will help people, do it. And I know I said walking, but walking out on a golf course, walking on the grass is much better on your knees than going to the mall. I don't know if people go to the mall anymore, but going outside in California, they don't go to the mall, but in Michigan, they went to the mall. So, go outside and walk around, on the concrete. That's really not good on your knees, on your hips, on the rest of it. So, these are the things I think. And people say, well, I really like running. I said, well, you also like not being in pain. So you got to pick which one it is. And I liked running when I was younger. I just don't do it anymore. So, and I think we all evolve. And so it's time to evolve and do something different as we get older. And I think so you can still live a life with joint pain. You can still live a life with joint replacement. You just have to kind of be smart about it. Just like you have to be smart with your diet, you got to be smart with that stuff.
I agree. So anything else you want to add for bone health in terms of, I think we talked so much in the last comment now. You talk about pretty much everything, how to maintain your health of your joints, replacement or not. And this is a phenomenal talk. I don't know if you guys want to talk about anything else.
I appreciate you guys having me on. I think we hit it, right? I think in summary, it's really, to me, I tell patients it's easy. It's healthy diet, lose weight, stay active any way that keeps you happy, and, include some weight-bearing exercises in there. And I think if you can do all those, you give your best chance for you not to need joint replacement. And if you have joint pain or need a joint replacement, you have your best chance of doing well after it. And you also probably have a good chance of keeping a happy life, happy heart, and probably keeps your family happy too.
Thank you so much, man. And if you ever come down to Orlando or anywhere in Florida, want to come say hi, we could get together, have some gin
someone
tonic.
ask for a G&T if I come down. There you go. That's what I want.
Exactly. So, please keep in touch. It's awesome. It's always, good to know an orthopedic surgeon over there. If we have friends or patients we can refer to, it'll be awesome. You guys have a wonderful night. Thank you so much. Appreciate it.